have to more lateral, no doubt about that.
Yes.
We have to go
Thorax
for
in this
because we
case.
are doing the supracostal puncture. Next is that direction, that should be our direction should. So I think there is a stone is sitting at the B. So we try to where the stone is at the level of A or B. It's more medial calyx. So I feel that A will be the better because we have the good entry and good space. So I think the A will be the best choice.
So one says B, option C, one is option A. Next one, please, sir.
I'll introduce myself first. I may not be familiar with most of the audience. I'm a urologist from Liverpool, UK, and punctures.
Keeping the nephrostomy tube longer, you are indirectly creating a nephropleural fistula.
Okay, sir. Well taken. So next, we always take a pre-operative consent for the need of an ICD insertion in supracostal punctures. This is a medico-legal point what I want to discuss, because mostly nobody suspects that this puncture is going to land up into a pleural complication. So in supracostal punctures, when you are definitely knowing that you are going through the hit the supracostal this superior calyx, so should we take a consent? Quick one.
Injury.
Okay.
You always make sure that that's including chest pain insertion.
Definitely. I'll run through. So this is a video I want to show here. Video नहीं play हो रहा है.
Sweet.
हाँ video play कर दो. The single puncture we have cleared all the stones. So I will be showing. क्या हो रहा है? Video. From the single puncture we have cleared all the. So can tract visualization while withdrawing the scope identify the pleural injury, and will it matter?
Yes, definitely we have to see that. If
Okay.
there-
So if you are suspecting, you should visualize the tract,
Yes.
and if it's there, you can anticipate about the complication.
pleural injury, and I usually put the nephrostomy tube in that.
So this is the tract visualization. So here you can see that easily one can see whether there is a pleural injury or not. Easily nahi. So
Yes.
it might sir. Yes. So second case is infracostal puncture. On the first post-operative day there was a mild pleural effusion, and on the post-operative day 6 it was completely cleared. So what do you suspect in these cases? It's an infracostal puncture. Yes. So well taken. So after it is a reactionary pleural sympathetic reaction which might lead to an pleural complication even though you are coming from infracostal region. So last one, spot the diagnosis and the treatment. So this is anyone? No.
This is extra vessels.
Yeah. So this patient was operated for PCNL. After 1 month, we did a RGP thanks to Dr. Gautam sir. There is a nephropleural fistula which has been created. So what is the line of treatment for this?
So number one, I don't agree that this is a nephropleural fistula, because the contrast in nephropleural fistula should go much lateral.
Okay.
It should first fill the CP angle before
Yes.
it fills anywhere else. Presuming this to be a nephropleural fistula, the treatment would be to place a stent, drain the bladder well, and wait.
Yes.
Okay, that's it.
Sir, it is not necessary to confirm, sir. We have an extravasation and we need to drain the system better. Nephropleural fistula would really present with chest symptoms, especially if this patient had a stent to begin with. And if there is a nephropleural fistula, whenever he passes urine, there would be reflux and patient should have symptoms.
If there is a suspicion, do a DTPA scan. Wherever there is urine and if kidney comes in, DTPA will go there and test will be done. No other test can show you whether it is a urine or
Oh, DTP.
Point well taken, sir.
Very well
DTPA
taken.
Yes,
should be
sir.
taken.
That's a good
then.
point.
Okay.
I thought of CT scan contrast enhanced, but it may be missed. How the fluid gone, DTPA scan is a good idea.
Yes, sir.
Very nice. I also want to know, sir, anybody from the audience that have anybody seen this fistula with pleura? We have not heard. Arun Chawla, sir, anybody institutional people? Come to mic, anybody, please, if you don't mind.
First one can store triangulation puncture will avoid the pleural.
Okay, sir. The discussion is fistula between the pleura and the kidney. Does anybody have seen and treated? Yes, Abhishek.
Sir, we have an experience of such a situation, but it was probably an injury that happened during the procedure. Subsequently, there was a cicatrization of POJ. So at the end of 1 month, patient presented with ipsilateral hydrothorax and non-draining systems. So he required a chest tube, a PCN, and once everything settled down, he actually required a ureterocalicostomy to get out of the situation.
So that's
This is an important
drainage.
point, that whenever there is a delayed pleural collection, there is always some obstruction.
Definitely.
Either a secondary cicatrization or some residual stone which has come down.
Yeah.
And if I can just give a comment on what somebody said about triangulation. Do not try to do triangulation for upper calyx. Do not be afraid of pleural violation. Going from subcostal towards the upper calyx would cause more bleeding than the risk of pleural violation.
Definitely, sir. Thank you very much.
Thank you.
Thank you.
Good.
panelists. Thank
Nice
you very
last
much.
case, Harshavardhan.
Thank
Nice
you,
case.
sir.
Thanks, Harsha.